just in a clinically relevant way, what happens when people's kidneys go down, and also why we do what we do, and some of the evidence / rationale behind it. So the learning points, there's three. So CKD metabolic bone disease involves lab abnormalities, which are, your calcium phosphate, PTH, your ALP. It involves the bone, clearly, but also not only is there bone involved, but there's also the blood vessels as well. So the way that we assess it is using all those markers, and then so when we actually manage it, it's just about avoiding complications which hyperparathyroidism does to a person. And so we do that by their phosphate control, by lifestyle, phosphate binders, or trying to nail down the parathyroids by vitamin D, the cinecalcids, anti-resorptives if we need to, and potentially taking out their gland. So in terms of a definition of CKD-MVD, so the old definition was something called renal osteodystrophy. You might have read about in old textbooks or heard about. And so that term has recently just changed over to CKD-MVD. And the reason for this is because it's become more recognized that that abnormalities in your phosphate and your calcium aren't only just from bone, because those minerals have to come from somewhere, which yes, do come from bone, but then they get translocated elsewhere, which is into the arteries, and that's why people have so much heart disease. So after withdrawal from dialysis, having a cardiac event is the most common cause of death, as we saw in our waiting room not too long ago. On top of that, so that's the vascular calcification side. And then there's people who have bone abnormalities. So, we've got people who've got Brown's tumours in their hip or whatever, or, a patient who recently passed. She passed because she turned around in the shower, fractured both her hips. And then you've got people who are in between, and it's all those three things together. So remembering that this same patient only a month or so before actually came in with a stroke. So there's elements of all those three things together. And if you think about it, there was lots of humming and ahhing about how this person's phosphate was actually really high all the time. So it's not really all that surprising that she had lab abnormalities at the same time. So to understand why this all happens, it is important to know a little bit about the physiology of it, and it can be a little bit complicated. But I thought what I could talk about is, the calcium, the phosphate, the calcitriol, and the PTH. So usually in the PTH, there's usually 4 glands in the neck. And what that controls is the level of calcium, so that if your calcium levels are too high, then it should drop your PTH level to try to modulate that. But if your calcium levels go too low, then the parathyroid goes higher in order to compensate for that. So if you've got a serum calcium, then that's what happens there. There's vitamin D. And so the active form is called calcitriol, but there's also the nutritional form, which is cholecalciferol, which is what we use a lot. And then so there's a few steps in the process, but essentially the punchline is the kidneys are involved in converting your nutritional vitamin D, the cholecalciferol that we might give, over to the active vitamin D in order to actually give those properties. So with the active vitamin D, calcitriol, then what that does is tries to increase up the calcium. So it does that by increasing the absorption of both calcium and phosphate through the gut. So in CKD, what happens is the bone releases this hormone protein called FGF23, and it gets increased and increased. And then so what this does is it decreases your the conversion across to your active vitamin D. So if you drop your amount of active vitamin D, then you drop your calcium level, and then therefore the parathyroids sense this and try to increase up to try to compensate for this. And it does this for quite well, because you'll see that people's calcium is actually normal, but the reason for that is their PTH levels is quite high. So the way that the PTH does this is it does it through a few mechanisms. First of all, it increases up the absorption of calcium from the gut, which is fine. It also increases the absorption of calcium from the kidneys, which is also fine. But then the last mechanism is it absorbs calcium from the bone by dissolving it, and that's not fine, because if you don't have your minerals in your bones, then you're more prone to fracture. as time goes on, then phosphate also has issues as well, and the phosphate continues to increase. And one of the other actions of PTH is as a phosphaturic hormone, so it tries to kick it out of the system. So if you increase your phosphate, again, your PTH goes up. If your PTH goes up, you gnaw more from the bone. If you gnaw more from the bone, then the bone releases your calcium, and also the other mineral in there is phosphate, because it's a calcium phosphate thing. So then you can see how you're going to get escalating levels of parathyroid hormone. And so that's the problem here. You're getting all your calcium from your bones, but also it's also depositing in other areas as well, because once the calcium goes up and your phosphate also goes up too, then they bind, forming a hard soap in other areas, which include the arteries. So what the process I've just described here is osteitis fibrosa, and that's the classical form of what we think of. If you do a bone biopsy, you'll see that the bone, it just doesn't form well. So here's the blue, which is the normally mineralized bone, and then the orange bit is the unmineralized bone. So that's one form. So if you've got a high PTH, then what you need to do is you need to try to control all the drivers, right? So as we talked about, a high phosphate will drive up your PTH. So you're going to try to control your phosphate, and we'll discuss how to do that in just a sec. You're going to try to stop them from getting hypocalcemic, because remember, low calcium means the PTH drives it up to try to increase up the calcium. And you're going to try to suppress the PTH with things like cinacalcet and vitamin D. And if all fails, then you'll go for parathyroidectomy. But that's not the only form of bone disease. There are 1, 2, 3 other types. So for instance, for adynamic bone, what this is in people, for example, who have had a lot of aluminium as a phosphate binder, then that affects the calcium deposition into the bone. And so essentially what adynamic bone disease is the bone is just at a standstill. So usually in people's bones, there's a constant turnover of resorbing the bone and also laying it down. But in adynamic bone disease, that just stops. And the problem with that is if you stop building your body, then any sort of trauma will increase over time and therefore lead to fractures. So the treatment for this is to actually try to stimulate parathyroid hormone, right? Because you want to increase that turnover. There is a balance between having too much turnover, as in the osteitis fibrosa, and too little. And so in those cases, you want to give them calcium. You want to avoid giving calcium to try to stimulate. You want to avoid giving vitamin D, which will also increase up the calcium. You want to avoid bisphosphonate. That's an anti-resorptive, as in it just stops the osteoblasts, which are the cells which lay down the bone. Other pathologies of bone might include osteomalacia. So if you don't get enough vitamin D, then the mineralization doesn't happen. So there's blue bone there, but there's plenty of unmineralized orange bone which is ready to get mineralized, but it hasn't been able to happen. And then you can get a mix of all the above, really. So if we don't do a bone biopsy because of how invasive it is and also how to interpret it, then the other way that we do things are just based on the bloods, which you guys do in hemodialysis. So essentially it's an educated guess, right? So you look at the PTH. If you have a high PTH, then you assume that there's a lot of bone turnover going, right? You look at their phosphate because you want to try to control it. You look at their calcium because you want to control it. And then you can also do a bone mineral density, which is the same thing that people do just for osteoporosis. So the DEXA scan is only a recent recommendation, because previously they were like, there's not enough evidence to actually use this. Because if you think about it, when you do the DEXA scan, it's just this image, right? You're just shooting a 2D beam this way into the body. So it'll pick up the bone bits, but remember, these people might have the same level of calcium, but it just might be in a different area, like in the arteries. But the DEXA scan isn't able to differentiate that. All that sees is there is bone in that plane that it's looking at. So it's not thought to be that reliable necessarily. There are research markers which are used in Westmead. Something called OSTASE, which is a specific subset of ALP, the same ALP that you do on labs. You'll see sometimes that people are high, and you don't know whether or not that's from liver, which is what it's meant to be testing, or that if it's actually ostase that you're actually testing. P1AP and beta CTX. Anyway, so there's lots of different tests that you can do, but they probably only give about 70% accuracy of which way you're going to go. And so that's a bit of an issue because you might get it wrong because, as we discussed, if you have adenic bone disease, you want to stimulate the PTH, but if you have high turnover with high PTH, you actually want to suppress it. So this is a guesstimate algorithm which was published a couple of years ago. So essentially, if they've got CKD with an EGFR of less than 60, because this is when CKD MBD starts to occur, then you look at all their risk factors and you can do the DEXA scan. If the DEXA scan says that there's a chance of osteoporosis given by the T-score, then you look at their bone turnover, and then you look at those markers which I just mentioned, their ostase, which is the bone-specific ALP. And so if the ALP is high, then that suggests there's high turnover, and then you're going to give anti-resorptives. If the turnover is low, given by a low ostase, then you might want to start an anabolic agent for them. But if it's in the middle and you don't really know, and it's just average, then at this point you do a bone biopsy. Again, is this really done? Nah, probably not. So in terms of the management of CKD-MVD, the management is really just to prevent the consequences of having a high parathyroid. I guess this is the end stage of what might happen in those with CKD-MVD, calciphylaxis. We recently had one, didn't we? Yeah. Yeah. They withdrew? Yeah, okay. So the risk factors, so the cause of it is unknown, but the theory is, as the minerals get deposited into the arteries, specifically the arterioles close to the skin surface, they block off, it dies, and that skin overlying is necrotic, and so therefore it might only look like a bit of a bruise, but it's really intensely sore because it's just dead. So the risk factors for this calciphylaxis is high phosphate, as we discussed, warfarin, because that's apparently meant to be increases the calcification of the arteries, and so you'll see that people here are on a Pixaban now rather than warfarin. Being female, white, high weight, increased risk of thrombosis, diabetes again is always a risk factor for arterial issues, and dialysis vintage. So clear that the longer you've got end-stage kidney disease, then the higher chance you will get calciphylaxis. So in terms of the management, for these people, it's wound care. Did we give sodium thiosulfate to this person? Did we? Yeah. And we had to check for metabolic acidosis by doing blood gases and things like that. Yep. Trying to normalize all the other electrolytes and stopping any other contributors. Was she on warfarin?
She was.
Yeah. So that was switched over to Eliquis. Yep. Okay. And the second line, hyperbaric oxygen, bisphosphonate, and then there's some novel things. But again, the prognosis for this thing is 50% mortality after 1 year. So essentially, you just throw whatever you have at it. So I guess to prevent these things, it might be worth talking about, the contributors. So in terms of phosphate, and Annette, maybe you can correct me, but in overall imbalance in a normal person, whatever goes in goes out. There is some turnover of the bone, and then there's some excretion from the colon. If you have 1,200 milligrams a day, then about a third of it goes through the stool, and the rest can be excreted out the kidney.
Sounds good.
Phew. The thing which isn't taken into control when we tell our patients to restrict the phosphate is just the variability of how well absorbed, because each person actually absorbs phosphate a little bit differently. You might see some people who are like, yeah, I'm really good with their phosphate, and you believe them, but their phosphate is super high. And you see some person munching on, a meat pie and their phosphate seems to be okay. And that's because there's a variability between people. There's also variability between if it's organic phosphate, as in from plants and meats, versus inorganic phosphate, which are things like processed foods. So to give a little bit of perspective, what is 800 milligrams a day? Well, something like a pork chop or a piece of salmon, like 100 grams of salmon, that's about 300 milligrams of phosphate. So that's already, a third of the way there, just from this tiny little thing. If we go through the Coke, so each can of that Coke is about 40 milligrams of phosphate. And if you have had 2 Tim Tams, that's about 50 milligrams of phosphate. And if you have a couple of squares of the Tim Tams, that's about 20 to 30 milligrams of phosphate. So in an afternoon tea where you've got one can of Coke and a couple of Tim Tams, you've already hit quite easily 100 milligrams. And then you go, okay, well, that's fine, but why don't I just take some extra binders and take it off? Phosphate binders aren't actually that good. So one tablet of Renagel will take off 26 milligrams of phosphate. So to neutralize one of those mini cans of Coke and 2 Tim Tams, you actually have to take 4 binders to make it right. So 4 times 26 is about 100 and 100 out. And that's kind of assuming that each Cevelma is actually as good as the one before, and you find that it actually binds less and less the more Renagel that you take. So by telling our patients to take 2 Renagels with each meal, you're probably not necessarily getting all that phosphate, and that's the whole crux of the issue. The other thing to think about is other hidden sources of phosphate. For example, the medications that we prescribe our patient. If you think about how many medications they are, we actually don't know. I don't know how much phosphate is in them. Do you? Yeah. It's all hidden, and it's not actually in the ingredient list of those of the medications. And then it also varies between brands. So if someone's on Coversil, that might be different amount of phosphate to someone who's on Prinapryl generic. Like it's just so hard to actually know. So if we were to talk about the different phosphate binders, do we have anyone on aluminium? At the most potent out of all of the binders, so it's the best. But the issue is, as we mentioned before, it causes osteomalacia or adenic bone disease. I guess the aluminium also goes into the brain as well, and they get a bit demented. So the other thing you can use is calcium, which is good if you're, I guess, in a different country because it's the cheapest to use. The disadvantage is, of course, you're adding calcium, so you might be worsening things. And they've done a study comparing calcium binder compared to Renagel, and they found that the mortality of those on the calcium binders is higher maybe because of the increased calcification. With Cevelma, it's a lot of pills to take. With lanthanum, maybe less pills, but still not that great. And the last kid on the block is the Velphoro, and that's kind of nice because you can also increase the iron just a little bit. The ferritin goes up by about 50 or so after a couple of months. So how else can you drop the phosphate or improve their calcium phosphate? You can do dialysis. So for each week of dialysis, whether or not it's hemo or PD, you remove about 1 gram of phosphate each day. So that's probably like a day's worth of intake for someone. So again,
so you've got the other 6 days to catch up.
Well, correct, yeah. They found that a calcium bath of between 1.25 and 1.5 decreases the calcium score in people's arteries. Whether or not that actually changes someone's outcome is still undefined as yet. So you'll have seen other patients on these medications: activated vitamin D, nutritional vitamin D, cinacalcet, and parathyroidectomy. So activated vitamin D is the calcitriol that we talk about. So what they will do is try to beat down your PTH, but then the issue with that is because it's activated vitamin D, then that means you will get an increased phosphate, as well as increased calcium. So when they've done the studies, they've been like, look, maybe we shouldn't use it in those until they hit dialysis stage, because we've found that it increases your rates of hypocalcemia and hypophosphatemia. Nutritional vitamin D is the cholecalciferol, I guess. There's different other types, but that also works up until CKD stage 4, and even, I guess, CKD stage 5 and dialysis we'll probably use anyway. Of course, it doesn't get converted over into activated vitamin D because you need your kidneys to do that, but there is some evidence to say that it does have some bone protective effects independent of it, and it's also meant to be an antioxidant and anti-RAS kind of agent as well. And because it doesn't get converted over, there's less chance of getting hypercalcemia. Cinecalcet, you might have seen there was a time where we could use it, and then there was a few years where we couldn't, and that was based on this study which said, yes, it delays the rate of parathyroidectomy, but it doesn't change mortality. So the PBS then stripped it from us, but now it's come back. Is the parathyroidectomy. So you can, because there's 4 glands, you can either take all of them out, or you can take 3.5 and then you implant the last half. The point of implanting it is you still want them usually to have a level of PTH secretion to turn over those bones. There's anti-resorptives. I don't think you guys will probably see much of that because all these things like alendronate, Actonel, all these things which are used in osteoporosis, they're not studied in our patients. So it's still kind of experimental at this stage. So up to an EGFR of 15, there is data to, but below that there really isn't. And that's the same with denosumab as well. Anabolic agents, I don't know if anyone's seen anyone called on teriparatide. Essentially what that just does is just stimulate the bone activity to occur there. The final thing is parathyroidectomy. So people who get parathyroidectomies essentially have failed all their lines of vitamin D, active vitamin D, cinecalcet, and over 6 months they're still kind of increasing, or it's just not getting better. So that's one indication. The other indication is calciphylaxis as a kind of an emergency kind of operation, because it's associated with better survival rates after getting your parathyroidectomy. So the benefits are you improve your calcium phosphate balance and you improve your survival, but at the cost of increased hospitalizations in the first year, because if you take out someone's parathyroids, then suddenly the bone says, oh, I actually need all that calcium, so it tries to get all the calcium back, and that's called hungry bone syndrome. The bones get hungry for the calcium, pulls all the calcium from the blood, the calcium levels drop, and then people can get issues because of that.